Ladies and gentlemen, the Family Caregiver Alliance would like to welcome you to the second half of our Caregiver Assessment webinar series. My name is Ken Molay, and I'll be acting as your facilitator today. I would like to introduce Adrena Harrison, our Information Program Specialist. Adrena, go ahead, please.
Thank you, Ken. I'd just like to add my welcome to yours. I'm so delighted that so many people were able to attend this second webinar on caregiver assessments. If you missed the first one from earlier this summer, as Ken mentioned, it is now available on our website, www.caregiver.org. The first one, as well as this second webinar today, will be available for downloading. Family Caregiver Alliance has worked for over 30 years to help improve the quality of life for family caregivers through direct services, research, public awareness, and advocacy. With our colleagues at ARCH National Respite Network, we jointly operate 2 technical assistance centers to support the aging and respite networks. To better serve older adults and their caregivers, the centers provide access to practical tools and multimedia. We maintain 2 websites with a national database of respite and model caregiver support programs and materials. We also write policy updates, sponsor specialized trainings, and provide individualized technical support. Our technical centers are actually funded by the U.S. Administration for Community Living, which is represented today by our program officer, Greg Link. Greg?
Thank you, Adrena, and thanks everyone for tuning in to the second webinar series. I've been very pleased to have the opportunity to work with the Family Caregiver Alliance for the past 3 years in developing tools and resources for the Aging Network as they continue to implement the National Family Caregiver Support Program. And as many of you are, I'm sure, aware, caregiver assessments are one of the latest issues that is bubbling to the surface, and our need to better understand the needs and preferences of family caregivers so that we can more effectively serve them is becoming more and more critical. So I welcome you all to this webinar. I want to thank our presenters, Dr. Kuhn and Joe McCord, for their time and for their expertise. And now I'm going to pass it back to Ken to introduce our speakers.
And that's just what I'm going to do. Thank you very much, Greg. You'll be hearing from 2 experts today. Dr. David Kuhn is Associate Vice Provost for Health Solutions and Professor in Virginia G. Piper Charitable Trust Faculty in the College of Nursing and Health Innovation at Arizona State University. He's directed a number of intervention projects focused on midlife and older adults and family caregivers, with an emphasis on programs serving diverse populations. He's been published in a variety of scientific journals, and his work with patients and caregivers from diverse communities was recognized with the Guenyo Award for Excellence in Research, Education, and Community Service in Ethnogeriatrics, which was presented by the Stanford University School of Medicine Geriatric Education Center. Joe McCord is a gerontologist and family consultant at the Bay Area Caregiver Resource Center in San Francisco. She received her Master of Arts in Gerontology from San Francisco State University. Joe has been with Family Caregiver Alliance for 13 years, conducting in-home caregiver assessments, teaching classes, and making presentations on topics which include understanding dementia and self-care. Joe also provides individual supportive counseling to family caregivers in their various caregiving roles. We're first going to hear from David Kuhn. David, you have the floor.
Thank you very much, and I appreciate the opportunity to talk with people today about this very critical issue that needs to be addressed, and many of you are actively engaged already in this activity. I want to just talk a little bit in terms of an overview of how our presentation is going to roll out today. We want to do a little bit of a background and justification about why caregiver assessment, and bringing people along who may not have been able to be a part of the first webinar that was carried out by FCA earlier. this summer. We want to talk some about key challenges for caregiver assessment, and I'll discuss practical issues that we've been facing in administration of caregiver assessment. And then I'm going to turn it over to my colleague Joe McCord to talk as a voice from the field, a person who's been doing these assessments for a good long time. And then Joe will pass it back to me, and we'll end with presenting some material about outcome-driven assessments. So to begin, I would like to start with I'm just seeing if the slide will move. Just one second here. There. Just a recap about caregiver assessment and how we might think about that. We think of it in terms of a systematic process of gathering information. It's going to describe a caregiving situation, and ideally it not only identifies particular types of challenges and needs that a caregiver might have, but also begins to uncover their resources and the strengths. We want to approach it from the caregiver's perspective and also really look at their context and the socio-cultural context in which they're providing care. And this really helps us focus on identifying what assistance we ultimately need to help identify and find to help support the caregiver in their role, but help them maintain their own health and well-being while they continue to provide this very important role. I'd just like to remind folks that many years ago, and actually several decades now, many of us have been referring to the caregiver as the hidden patient, the person that stands behind our care recipients. They're often at risk for a variety of things, including clinical depression or symptoms of depression, extreme fatigue, stress, anger, anxiety, worry, concern, feelings of being overwhelmed, but also they're often socially isolated. Unfortunately, in working with caregivers for some almost 30 years now, I really have seen over and over again that our society isn't the best at reaching out to others who might be in this role and helping reduce their social isolation. And in these uncertain economic times in particular, we see people having concerns about the financial losses and expenditures that go along with caregiving. But caregivers also come to their role with their own physical health problems, and sometimes we forget about that. And sometimes they come with multiple comorbidities. And my colleague Rich Schultz and his colleague Scott Beach demonstrated back in 1999 that stressed caregivers are also at risk for mortality. So we really need to keep that in mind about the importance of caregiver assessment to help us get a handle on what particular caregivers might be experiencing. I also would like to point out that the value of what our family caregivers provide for us and the reality of rising healthcare costs out there is quite staggering. In 2000, 42.1 million Americans provided unpaid care for another adult with ADL limitations. And when we look at that year at any given point in time in that year, some 61.6 million people provided unpaid care. When we take this and we paid those individuals for what they're doing, the economic value of their unpaid contributions is in excess of $450 billion. To put that into another perspective, that exceeds Walmart's sales of $409 billion in 2009. So we really recognize that family caregiving is the most important source of assistance for people with chronic conditions, those people that need assistance in our long-term support and services environment. They're often the care coordinators as well. We need to keep that in mind, and they're doing that often without a net. When you think about your own struggles with care coordination and finding things for the people, think about individuals that are often doing that without assistance out there. So when we think without this informal workforce that we so depend upon, the entire healthcare system and long-term care system would be in jeopardy. Family caregivers are truly our backbone. They're the bedrock of our system, either fits. And I need to remind us, I mean, even though that we're looking often at people maintaining the health of their care recipient in the homes and aging in place, caregiving doesn't end with placement either. So I'd just like to pause for a moment, and many of you probably remember this. All I ever needed to know, I learned in kindergarten, thinking back to Robert Fulghum and that lovely poster and the cards and everything that we see that on. And while that makes us feel good on one hand, on the other, I need to remind people that I don't think Robert Fulghum was ever a family caregiver, because I don't think we were trained in kindergarten about how to do all the kinds of things that family caregivers need to do. And again, it's critical. The caregiver assessment helps us identify what assistance that we need to begin to provide and connect folks to maintain their own health and well-being and sustain them in their roles. So now I'd like to switch a bit to the key challenges in expanding assessment to our family caregivers, how to move from that, and how to balance their needs, the needs of care recipients, utilize our clinical judgment in line with our structured assessments. I'd also like to pause, though, just for a moment about some of the background and perspective of where I'm coming from today. Many of the key points are drawn from my own personal experience with the caregiver helping develop the Arizona Caregiver Assessment Tool, or CAT as we refer to it, and also drawing from the New Jersey Care Partner Support Pilot Program. But these points really are very similar as I talk across the nation with the experience of others that are trying to take family caregiver assessment and integrate it into their system. No matter what, really the reality is that the assessment and service provision really to date has typically focused solely on the care recipient, and now we need to think more strategically about how to integrate the family caregiver assessment with that. Just a couple of points. You have the slides. I won't go into detail, but when we look at the CAT tool, we really utilize that to help us begin to assist in respite allocation and identification of relevant services for family caregivers as part of our pilot and lifespan respite program. We drew information and reviewed the various scientific and practice literatures. We drew from measures that we have seen that might have strong reliability and validity, that are established in diverse groups of people, might be sensitive to change with intervention, and how it could be also tied with what is being assessed in the care recipient. Now, everybody had their favorite domain, so we really had to come back to the reality of time constraints about how to really have that happen. So we refined it through a variety of discussions through stakeholders, providers, administrators, family caregivers themselves, and we ended up with an interview-administered CAT, Caregiver Assessment Tool, that looks at caregiving activities, the impact of behavioral challenges, the health and well-being of the family caregiver, social support, and the like. And then we also have a project evaluation that's done post-only after services are provided to understand better the impact of those services. The New Jersey Caregiver Partner Support Program shares some of these, but is a little bit different too. Its real focus was to improve the knowledge and skills of family caregivers that were caring for adults in Medicaid programs. It's self-administered by contrast and designed really to help guide the care managers in terms of information and referral to meet the needs. And it also covers similar kinds of domains as what goes on in the CAT. It's really not intended to be an intervention that resulted in behavior change, but really to help care managers be more aware of the caregiver needs and promote good professional practice. And it, in turn, helped the care managers provide a packet of materials. There was a follow-up phone call that was done and then a follow-up mail survey. Out of these kinds of activities and programs that are starting to utilize caregiver assessment, I've really seen in my own experience as well as talking with others across the nation that we kind of come up with a challenging wish list of what people would like to see in caregiver assessment. User-friendly, staff-ready, not very intense, providing less time away from activities, because we all know that the reality of case and care management is it's very they're very busy individuals. You all, many of you who are on the phone that serve in this capacity are very, very busy individuals. So how do we make it short, brief, but meaningful? How do we integrate clinical judgment and structured assessments? Getting feedback that from some folks, as we know, can kind of come to this frame saying, I already know what these folks think and need. But how do we begin to integrate that with a more structured assessment that we do consistently with all of the caregivers that we come in contact with? How do we go ahead and marry those two together? How do we deal with forced choice issues? Because structured assessments, and one of the complaints I get from care managers is, you know, people don't always like those forced choices. So part of what we do is also have open-ended at the end to be able to discuss more and get feedback from the care managers as well as from the caregivers a bit more about their experience and tie the two together. How do we appeal to, and it needs to be effective with caregivers from diverse backgrounds? I have a slide that talks a little bit, very briefly, about the complexity in the context of care. We have to keep in mind that if we're doing something that's structured, and even in our clinical judgment, that there's differences in terms of the meanings of illness. Whose family? I learned early on in my career that I could be working with a family and thinking that we're making great headways on a care plan or the like, but the reality, the people that also had a lot of input in the decision-making actually weren't even in the room with me, and they weren't even in the same state or necessarily in the same country when it came to recent immigrants and the like. So values, attitudes, styles, and patterns of communication come in, and defining what's acceptable behavior. So even though we have structured assessments, sometimes we've learned that there are certain people from certain backgrounds that don't seem to have as much problems with some of the challenging behaviors as others. I think also we're seeing in our world today more challenging caregiver contexts, and I would imagine many of you are experiencing this. Care recipients are released sicker and quicker out of hospitals. There are a variety of colliding and multi-generational households in terms of personality styles and complicated situations. The alcoholic, unemployed son is moving back in while grandma is trying to care for granddad and brought some of his children with, and so it's a very complicated situation. And not just one that's solely built on the dyadic relationship of the care recipient and caregiver. And of course, we're in these times of financial stress and strain, we've got layers of that as well. So back to the challenging wish list a little bit. People often want these tools to also be married with existing programs that help us easily identify what kind of referrals or programs are needed out there. They would like for it to be evidence-based and empirically supported, very much buzzwords that we hear often out there, but also that the programs that they refer to help meet the needs of their caregivers are also evidence-based and empirically supported. Now, in ending a little bit with this challenging wish list, thinking about the reality that caregiver assessment is multidimensional, as we've already said, and it needs periodic review and update, and it needs to reflect that responsive practice as well. In terms of addressing a few of the practical issues, I always remind people that are training their staff about in caregiver assessment, it's really about some element of technology, but it's also about a lot of art, that coaching of using the clinical judgment and keeping moving if there's a structured assessment. The privacy and phone, we experienced this with the CAT administration, often having to call back because people were concerned about the care recipient's reaction to the caregiver's response, but those response sets often shift in the assessment, and that can be more challenging to do over the phone. We saw in the New Jersey pilot, as well as in our own, there is a time trade-off with either type of administration. Often an interviewer administrator, you have the time to respond or answer questions about it in real time as you're going through the questions. But in self-administered, I think they experienced in the New Jersey pilot that the caregiver would come in and say, I don't understand what this question means. What do you mean here? So it's not quite as simple as it seems. And then literacy issues come into play as well. But in any case, helping the caregiver see the assessment is really worthwhile as an opportunity for them to express their views. We encourage our folks to really think of it as a matter-of-fact approach. The goal is really about getting good quality information from our caregivers to help them and the tools that they need that help them sustain their role and assist their care recipient. Encouraging people to relax and be themselves even when questions become a bit challenging or somewhat awkward. We ask some negative coping questions. Do you turn to over-the-counter drugs, more cigarette smoking, a bit more alcohol in stressful situations to help us identify people that are at risk? And that can be a challenging question, but if we have a good solid introduction to the topic, sensitive topic, that can be done. So we encourage people to utilize those scripts, practice those scripts, so they have those ready and as part of their repertoire as they move through the assessment, and it can ask those questions without embarrassment or apology or criticism. Many times people, you will need to ask for clarification, or they will ask for clarification, and the importance of training people on how to not pitch a response back but give a matter-of-fact choice to the individuals. sometimes we've got pushback when we were first doing this because people would say, I can't add that on. Caregivers aren't going to want to do that. They're stressed. But in reality, we really have seen that most caregivers really welcome the intention support, particularly if it's aimed at trying to support them in the role and helping them to continue to provide care. A couple of examples of these types of challenges: troubles choosing between two answers when it's forced choice. We give people, these kinds of prompts for them to practice and have on hand. Well, which comes closest? I understand that it seems, there might be something a little bit in between, but we only have these two choices, so what would you say fits best for you? And then offer to make a note of their suggestion if they have an idea about how something might be worded differently or the trouble that they had in making the choice. We have unclear what the caregiver might mean. Well, would you tell me a little bit more about that? Really explaining that. And this is where the kind of clinical judgment comes into play and the clinical skills that people have that really helps them move through a structured assessment. People lose focus of the question, and you must get the caregiver back. It's a little bit like the next one. Caregiver wants to tell his or her story in an unfocused way, or they go off on something tangential. I think we can all relate to this. You're bringing up very important issues, but I also want to be respectful of your time. So let us get through these questions. I'm going to make a note of this, and let's discuss more later about it. Right now it's important that I get all this information so that we can help determine what might assist you best. So now I'm going to turn it back to Jo as a voice from the field to give her some of her experience in using an assessment tool. Jo?
Thank you very much, David. I have worked with caregivers for about 13 years now, and during that time I have found that the assessment tool can be an opportunity for learning, but also presents a list of challenges. It's important to remember that the assessment is both an instrument and a process. The helping professional uses the instrument during the facilitation of the process. The assessment should result in a plan of care that describes the provision of services and the intended outcomes. I find that it is often helpful, actually, to begin the assessment with open-ended questions, because that tends to start a dialogue that encourages the caregiver to open up. During this dialogue, communication styles are adapted and used to establish a rapport with the caregiver, which often reveals more of the issues and challenges faced than initially expressed during the intake process. As an example, I remember one of my cases in which a caregiver was initially quite guarded because her prior experiences were in relation to her husband's needs after his discharge from the hospital. The questions asked by the discharge planner were brief, and the setting, as you can imagine, was very hectic. At no time were her needs addressed relative to caring for her husband. When I went to her house for the assessment, she was extremely reluctant, even to sit down and to answer yet more questions. When I explained that the assessment was about her needs, and when we started to discuss them, she was visibly relieved and let herself express a host of emotions that she had not expressed out loud since her husband's illness began. Often caregivers feel a mix of emotions, but don't have the opportunity to acknowledge them in a meaningful way and are often surprised at how they feel. After establishing a foundation, it's then easier to move into a series of structured questions, which may involve questions of a private and a more intimate nature. The direct response also serves the function of getting the caregiver back on track, as David mentioned briefly, and it also tends to focus the caregiver directly on the assistance they may need. For example, a female caregiver in her late 70s was having difficulty getting her husband to bathe. Her husband had Alzheimer's disease and was resistant to having his wife tell him what to do. I explained to the wife that this job might be better suited to a professional, in other words, an attendant, who might have better success and would certainly help the caregiver to maintain her own health and well-being. This approach has been helpful in obtaining information which can help the professional, A, to use his or her clinical judgment to identify other needs and contributing factors, B, to understand the context in which the caregiver is functioning, and C, to see how the responsibilities for the care recipient are affecting the caregiver. If there are multiple caregivers within a family, a group interview may be needed. Sometimes clarification of roles, what information is needed to carry out their tasks, and oftentimes conflict resolution is also needed. As an example, I did an assessment with a woman who was the primary caregiver to her mother. The caregiver was the youngest child in a family of 5 and was having difficulty communicating with her older siblings because they were resentful of her role as the person who had the legal powers over finances and health. I explained that this was a decision made by their mom and not the caregiver, and that the goal was to honor their mom's wishes as a family. In summary, as a practitioner, I think that in training staff to use an assessment tool, it should be stressed that the assessment should be multidimensional and it really needs to be updated periodically. Also, a reassessment should really be built into the process, perhaps every 6 months if that's possible. The caregiver assessment should have a family-centered perspective and include the needs and preferences of both the care recipient and the caregiver. I also think that follow-up is very important because oftentimes caregivers become distracted or overwhelmed, and even after the information and resources have been provided to them, they are too overwhelmed, and it's important to keep that in mind. David, back to you.
Thank you, Jo. We'd like to end today talking some more about outcome-driven assessments. Many now really consider the stress of caregiving and care to be a public health priority of national concern. It's taken from the CDC and Kimberly Clark's publication, a monograph that's easily available online for those people that are more interested in that kind of view and perspective. When I think about outcomes, I think about what and when. What do we want as an outcome? And it's probably going to shift by organization. And what is critical and important, and what is the purpose of the outcome. And so I've listed some options here, some of which may be put together in a package, and we certainly tried to do some of that with the CAT. But symptomatology, what symptoms, things like caregiver depression, caregiver burden, the impact of patient or care recipient memory and behavior problems, or more quality of life kinds of things like caregiver self-efficacy, changes in more adaptive coping away from negative coping. Many kinds of assessments and evaluations are often driven by social validity, caregiver perceptions of how useful a project was, or a program or a service. And many of those have really been focused here to date on caregiver satisfaction with those services. But I think we are taking more steps forward and also looking at post-evaluation after services that can move towards things like the person's ability to continue to provide care at home. Their perceptions of those kinds of activities in terms of the social validity of a program or service. Social significance. We can also do evaluation or outcomes in terms of the cost of implementing not only the assessment but also the programs and services. You might follow that as well in terms of, are there changes in the amount of service utilization? So these outcomes can range across this. And the amount of service utilization can vary in terms of what your purpose is. If you're interested, of course, in enrolling or engaging underrepresented caregivers into your programs and services, you might want to see service utilization go up. But it also could vary by type of service utilization. We certainly don't necessarily want more ER visits to go up versus finding other ways that maybe serve those families with less cost. As Joe alluded to, timing and reassessment is critical, and it can vary based on the needs of the organization. And it may be what's the impact of the program. So the program lasts 3 months, but then there may also be reassessments to see whether or not gains that were made by the caregiver during this time period are maintained over a longer period of time. We've both Joe and I have talked about the importance of revisiting the assessment and updating it. But that, of course, presents some kinds of challenges for outcomes, because changing the outcomes means that you are comparing kind of apples with oranges. So when those updates happen, need to be thought of pretty strategically. I think there are some, when we think about doing more outcome-driven assessment and integrating that into our system, it comes with challenges and opportunities and really a paradigm shift. When we think about the differences between care management and behavior change focus, how do we integrate those? And professionals have vary in terms of their prior training, their interest, what counts within their organization in terms of the importance of behavior change or looking at these types of outcomes. The outcomes that I had on the previous slide really often depend on helping caregivers change their behavior and having providers learn additional behavior change skills in programs and services to help support that. I've really found that as I've begun to work in a variety of different programs with care managers out there, at first there may be resistance, and again thinking of it as an add-on, but then moving to really seeing it as an opportunity to learn more, do more, stretch their skills, gain additional skills that they find are useful in other arenas of their work life as well. But I really think that this is also an opportunity for us to really look at the critical sustainability of programs. And so having that information can be very important in the viability of ongoing programs and services. In terms of training and fidelity, we often work from a say, show, do, and review kind of model. That the structure and process of caregiving assessment training, there can be an initial training, there can be observation of others doing it, there can be supervised delivery, feedback, and providing that feedback loop so that care managers or those people that are doing the assessments really feel like they have a voice in giving feedback about how is the assessment doing, how is it integrated with their clinical judgment, how can this be done more effectively. Structure and process for the programs as well. You know, where are we in terms of the program development and how is that integrated? Are these the needs that are identified for caregivers, are there programs and services available in the area, and do those help foster the kinds of behavior change that lead to the outcomes that we're looking for? This raises additional questions. Who's going to administer, collect, compile, and utilize this data? Is it the referring agency that's doing the assessment, or is it the agency that conducts the program and service, or are they one and the same? How do we share information across this to help improve the quality of life, not only for the care recipient, but also for the caregiver? And as I mentioned before, what are the programs, services, and interventions, and what are their targeted outcomes that exist in our catchment area that we're referring people to? It requires ongoing need to update our resource guides and to identify and fill in service gaps, and for people that are engaged in caregiver assessment to have a voice to help guide that. And then there's the reality of who's going to pay for them. Without the kind of funding or reimbursement, organizations might not be able to commit to the caregiver assessment, full caregiver assessments and information referral, much less the additional programs or services that are needed to address family caregivers and services. So I think there's hope. I think that there's an opportunity, and we've seen some cost reductions in helping support caregivers in their role in terms of some of the scientific and practice literatures. We can develop better workplace policies, on-site education and support that helps sustain caregivers, integrating caregiver assessment into publicly funded HCBS programs, hospital discharge planning, chronic care coordination activities, care transitions, and then even in terms of new models of care under the Affordable Care Act. I think there's an opportunity in expanding funding for the National Family Caregiver Support Program and Lifespan Respite Act to help caregiver assessment continue to be activity integrated into this. I think we can take steps to encourage our health and social service provider professionals and that we work with to integrate informal caregivers really as part of the care team, as full partners in helping do that plan and continuing to do our information and referral to caregivers to the supported services that exist in the community. I have a bias. I think there is a medical home, and I think I have pictures of all different types of medical homes right there. The vast majority of what still happens out there happens in our own homes, and we need to remember that and continue to figure out ways to support that. Family and formal support is essential to helping people remain at home and in the community, and I firmly believe that better caregiver assessment and response to the needs of our family caregivers through public programs that help provide these types of services really needs to be a public policy priority both at the state and federal levels, and we can have a voice in that. I want to close a little bit about in terms of an ethic of care. I really come from this frame that really it's viewed as a relationship that is the balance of self in the family caregiver or care partner and a constellation of other caring others, and that may include the care recipient as well, to be engaged in their continued health, as well as paid workers and direct care workers and other family members. It's not really to be conceptualized as an initial position of the caregiver concerns versus the care recipient concerns, but a balance between the both, because that's what helps us maximize the quality of life of both care partners. In doing so, I think we can better capture the full range of the caring community, and that's going to lead us towards healthy aging communities where caregivers and their care recipients as full partners are really seen and integrated more psychologically and socially into our society. Finally, caregiver assessment is the fundamental building block, I think, of an ethic of care. We all know that when the caregiver is at risk, so is the care recipient. So taking care of the caregiver remains to be critical work, and caregiver assessment is a part of that. I want to remind folks that at the end of your handout there are references that relate to this presentation, and I'm going to turn it back over to Ken for questions or comments.
Unmuted.
Thank you so much, David. And as you can see on your slides, I've also put this link into your chat box. I made a short URL so that you can download a copy of these slides. And some of the things that David was talking about, we do have quite a few references for works that he was talking about, for additional readings that can help you out. And I'm just flipping between those rather rapidly at the moment, but I want you to know that they're all there in your handout, which you can get from this download link. And let's go to some of the questions that came in while you were talking. David Hollis pointed out early in your presentation when you were talking about the Arizona and New Jersey pilots, he said many family caregivers are now paid caregivers who are helping in the use of self-determination and self-direction options. Did you include, or do you know if paid family caregivers were included in those pilots? And if so, were any differences found in the application or results with paid family caregivers?
What I do know is that we're in the midst in the CAT tool. We have about between 600 and 900 of those coming in this coming year. So we're really looking at the outcomes over that. I believe that there will be some paid family caregivers in that. I am not completely certain in terms of the New Jersey program, whether or not paid caregivers were included. I do know that the analysis that I looked at did not break it down in terms of that, so I don't know the information. But it's a very good question, and it's something that I will certainly raise with my colleague David Best, who's worked with me on the CAT and is our caregiver resource specialist for the state of Arizona in terms of looking at that. And so if we can find that, David, my email is on here, so please send me an email, and in a year or so when we've got it, I can send you some of that information back.
Okay, great. The next one I'm going to ask is comprised of the same question from a number of different people. I'm looking at Naneda and Serafina, and they want examples, details. What questions should be asked? What are the open-ended questions? What are examples that you can give us? Are you willing to share any of the questionnaires that you have used in the past?
Well, I also want to hear from Joe on this too, but the New Jersey program, and if it's not in the references, we will definitely make sure it's in the references. You can pull it up. It's the Hilltop Corp did the final paper on that. It's called the New Jersey Care Partner Support Pilot Program, and the Hilltop Institute did it in coordination with the University of Maryland, Baltimore County, as I recall. And so you ought to be able to pull that up as well. Woodcock is one of the first authors on that, and Greg may have some more information on that as well. The types of questions, we have the CAP that we're currently under evaluation, but we ask questions that were married with the care recipient assessment tool. And so we have questions that we can share parts of. There's some that still are under investigation, as I mentioned. But for example, in the post-evaluation piece that I was mentioning, I think I had one listed there. But there are questions like, how much do you think you benefited overall from this, sort of from the social validity side? Are you how much did receiving these services help you feel more confident? Did it help you make your life more easy? Did it help you in terms of enhancing your ability to care for, help improve your care recipient's life? But we also have questions that relate more specifically. We use the brief version, the 4-item version of the Xeric burden as some of the questions. So what I hope you would also take away is that it's going to depend a bit on what your organization wants to do in terms of an assessment. I think that there are key domains, and you have to look at how much time you have. And I'm going to turn it a little bit over to Jo, if she wouldn't mind, talking a little bit about the types of questions that they do in their assessment. And I know that there is an assessment on Family Caregiver Alliance's website, and if not, please correct me, Jo.
Thank you, David. Yes, there is, and excuse me. Some of the open-ended questions that we ask, just to kind of get the ball rolling, is, who is helping you caregive for the care receiver? Do you have family support? Do you have friends that are supporting you, that are actually involved in the care process? Family members, and also we ask if there are paid attendants that are involved in the care. The other questions that we need to get answered are basically questions like ADLs. Does your loved one need help walking, bathing, grooming, dressing, things of this nature, so that we can then figure out the level of care they need to provide for the care receiver. I think also issues of incontinence and things like that, it helps me better able to provide them with the resources they're going to need to continue on their caregiver journey.
And I might just tag on that, off of that Joe raised the issue about what are the care recipient's needs, and then part of what we married as an example to this is saying, let's say someone identified incontinence. Then you mentioned that you needed to help the person with this. How hard or stressful is it for you to handle this, the incontinence? And so that gives us a stress level, a concern. If that's not a concern, that begins to help guide where the person may need assistance. And what programs or services might be available that would fit them. And so some of it IADL, some of it ADL, some of it mental health and behavioral, those kinds of things. So particularly in the CAT, we marry that assessment that happens in the care recipient by follow-up about how upsetting or stressful it is or hard it is for you to handle these kind of problems. And I think that's a good step. Yeah.
And if I could just say,
go ahead, Joe.
If I could just say one more thing, and even if the care recipient does not have these issues presently, it helps the caregiver realize that if these problems occur, how well equipped they will be to handle them in the future, and that's good information for me to help them as well.
Okay, Joe, this is Edrina, and I'd also like to add that some examples of caregiver assessment instruments actually are on the Family Caregiver Alliance website. Again, our website is www.caregiver.org. If you'll click on the website and then go to the section where it talks about archived webinars, in our first caregiver assessment webinar, there is an attachment, the PowerPoint slides, and they make reference to various caregiver assessment instruments. And there's also a link there to actually look at some examples of the instruments. And if any of our listeners today have any trouble actually locating those documents on our website, please don't hesitate to send me an email. Again, this is Edrina Harrison. I'm with the Family Caregiver Alliance. My email address is eharrison@caregiver.org, and I'll be very happy to make sure that you get the examples that you need.
All right. Thank you, Edrina. Let's move on to another question from Sani. Sani wants to be a good advocate and talk to legislature. They often want to know how our programs help save money. Is there a way that we can tie outcome measures to cost savings? And David, I'll throw that one to you.
Okay. I think, yes, there's growing evidence of this in terms of, and I think there's a good summary of some of these ways to talk about this. Actually, I was just reviewing it not only in the AARP reference that's in there, some of the fact sheets and valuing the invaluable that could help you get some tips about ways to talk about those kinds of things, but also even in terms of the Hilltop report on the New Jersey pilot program, talks about key aspects that I mention in one of those slides too. So I don't know whether Joe or Edrina or Greg have any other ideas of a good off-the-top one-stop shopping citation for somebody, but that's what's coming to mind right off the bat. The AARP fact sheet, Lynn, here they are. Ken's putting them up on the reference list, has some good statements in there that can be useful for us. And I think critically, just really people understanding of keeping people in supporting family caregivers to continue to do their work. When you start translating the kinds of dollars that I mentioned before, makes a quite powerful statement to legislatures. There are right now a series of ADSSP projects that are coming to a close that will have some additional information about the cost of those programs in supporting family caregivers in a variety of states that were funded as projects through the U.S. Administration on Aging. So we'll get some more information on that. So I don't know whether other panelists have some additional comments on that.
I just wanted to say that there are plenty of statistics and plenty of papers out there that describe the cost of care that caregivers are providing the individual they're caring for, and the savings to rather than having to place their loved one in a skilled nursing facility. It's the amount of money is unbelievable. The cost, the burden that's absorbed by the caregiver.
All right. While we're on the subject of advocacy and legislature, Kathy was asking if you know of any examples of states that have incorporated a caregiver assessment into their waiver assessments. And if so, do you know how advocates were able to get caregiver assessments included?
Very good question. Joe, are you aware off the top? I'm sure there probably is, or Greg, I don't. Off the top of my head, I don't know.
No.
Because it's being evaluated, I think, about how to do that.
Yeah, this is Edrina again. I think one model that we might want to look at is the work that was being done in Texas. Family Caregiver Alliance did a webinar looking at their caregiver assessment model and their process a few months ago, and it too is on our website. But I would probably start with their approach and what they did. And again, if anyone needs some additional information, please just contact me by email, and I'll be happy to follow up with you and perhaps be able to provide you with a couple of other examples.
Okay, let's move on to an interesting question put to us from the Fundación Alzheimer in Aruba, listening in today. And this is talking about multicultural aspects, international aspects of care, when you might have belief systems that are foreign to the caregiver. For instance, you might have somebody who believes that Alzheimer's comes from voodoo or a different belief system. How can you cope with this in your interview and assessment process?
Well, thanks a lot. Hi, this is Joe. I think that, having done this for a number of years, and when I talk about there's a level at which you have to speak the caregiver's language. I don't mean their native tongue, but I mean how they approach certain diseases and talking about certain diseases. So I have to tune into them when they're talking about this and how they respond to doctors, how they interact with doctors. And I am very careful to be sensitive to what their needs are. If I can interject something for them to think about with relation to how I see the disease, then I will attempt to do so. But I, in many cases, will just listen and based on what I understand, try to provide what I think is appropriate in that situation. Does that answer your question?
Okay, we'll let them type in again if that is helpful or if there are a few more things they want to cover in that area.
Well, I might also add I agree wholeheartedly with what Joe's saying. I think that what I also try to keep in mind is that there's a difference between, while they're interwoven, there's a difference between the stress and strain that a caregiver is experiencing and their belief system, about the illness. They're interwoven, but sometimes I think we worry too much about trying to figure out how we encourage them to come around to our way of thinking. And Joe wasn't doing this at all, but some people do, versus really concentrating on what they need to help sustain them in their role. And what I heard Joe doing is beginning to, if there's an opportunity to say, this is what I hear you saying about your understanding, this is what my belief system is, or some of what we see going on. It might be married, it might not be, but if you're really dealing with what the individual is having to face and focus, the stress and strain that comes along with family conflict about doing this, the stress and strain that comes along with incontinence or wandering or whatever it is, that can be handled sometimes within the frame of the stress of caregiving versus the frame of their belief system about the etiology of the illness. Does that make sense?
It makes sense to me because you're wherever the problem came from, in that kind of situation, I think that you can still provide help and assistance just by the basic needs of what occurs as a result of those behaviors.
Right.
Okay, great. I just want to call attention to a little help from Sonny, who wrote in. I'm hoping that when I sent that back out, everybody could see what she wrote. But pointing out that the AARP Public Policy Institute paper on assessing family caregiver needs, policy, and practice considerations does talk about aging waiver programs, including caregiver assessments. So that's a good one to look for. And we probably have time for one more question we can slip in before the end of the hour. And I have to pick and choose because we've had a lot of people writing in about very specific care areas. And of course, everybody's concerned about the ones that they work with the most. You have the needs of special needs patients, lifelong care that may be children, not just elderly patients. You have people with intellectual and developmental disabilities. And are there any tips for dealing with special case situations and advice that you can give people working in those situations?
Well, as far as Family Caregiver Alliance is concerned, we we only deal with elders. So I don't really have an answer to that question. David, do you?
Well, Ken, can you just repeat it? For some reason, my headset just went a little funky on part of it, and so I'm sorry to ask for a little bit, but if you could encapsulate it.
Sure. Do you have any advice for caregivers who are dealing with special case situations? For instance, you might have parents of children with special needs who need lifelong care, not just elder care, or you have people with intellectual and developmental disabilities. We had somebody else that was wondering about specifically family counseling issues. So how can people find better resources and better advice for dealing with special case situations?
It's a very good question. I am less knowledgeable about that because most of my work is focused on midlife and aging kinds of issues. When I have been asked to speak, a lot of the same kinds of skill and education training, stress management, managing challenging behaviors that we have seen work effectively when I've spoken to groups that are addressing this, and it's happened 3 times in the last 5 years, they resonated with that, but I'm less aware of what exists in terms of specific programs or organizations. So I would look to organizations that might help support those individuals and those families and see what kind of material. But what we do know from some of the literature is that helping them with stress reduction, do management, incorporate pleasant events and activities into their lives, and finding time that the parents themselves have for themselves is effective as well. So.
And the only thing I can add really is that, you know, I do believe strongly in having family meetings just so that every individual within the family can address the issues that are obviously going to be ongoing, and so that at least the family decides on a goal and how to achieve that goal.
Okay. Well, thank you. We have run right to the end of our time and maybe a minute over. I'd like to thank you for attending today, and a big thank you to David Kuhn and Joe McCord. That does end our session. Once again, you can look for the recording in probably a few days. We'll have it up and available on the FCA website. The address is right there at the bottom of your screen, as it has been on all these slides, caregiver.org. Thank you. That does conclude our session.